Right in with some questions here. Well, here, hold on. Okay, so we already reviewed receptor types. All right, in terms of structural comparison, the location of the CNS component is different for the sympathetic and parasympathetic. The sympathetic is thoracolumbar, and the parasympathetic is craniosacral, so top and bottom. The preganglionic fibers and postganglionic fibers are different in the two. In the sympathetic, we have short preganglionic fibers and long postganglionic, and then in the parasympathetic, we have the opposite, long preganglionic, short postganglionic. All right, and then the neurotransmitters. Norepinephrine, epinephrine for the sympathetic, and then acetylcholine for the parasympathetic. All right, so let us do a question. Are you guys logged in? I'm not getting any answers yet.
I am.
You are? Here, let's see if I can... I don't have any answers. All right, I'm going to end it anyway. All right, so sympathetic stimulation of the postganglionic cells of the adrenal medulla cause the release of which of those things? We had a bunch of people come in. All right, I think that's everybody. All right. So all you really have to know here to make a good guess is that the adrenal medulla secretes epinephrine and norepinephrine, right? So that makes C the correct answer. So what are they talking about? What they're talking about is for the adrenal gland, instead of having postganglionic neurons, we have a postganglionic gland. So sympathetic stimulation of the adrenal gland, which is postganglionic, causes the release of epinephrine and norepinephrine into the bloodstream. Instead of it into a synapse, it like releases it into the whole body, so it has a very widespread effect. All right. So the two classes of adrenergic receptors, well, we're going to skip that because we haven't really talked about that word. All right, vocabulary. Cholinergic and adrenergic, because you may hear those words in questions or in your book. What we're talking about is when we look at a neuron, so here's one and here's one, right? We can define that neuron based on its neurotransmitter. So if a neuron releases acetylcholine, we call that cholinergic. That's a cholinergic neuron. If it releases epi or norepi, we call that adrenergic. Now this is because adrenaline is what we used to call norepinephrine and epinephrine. So an adrenergic neuron releases epi and norepi. So adrenergic and cholinergic. Okay. Let's try again. When acetylcholine binds with nicotinic receptors, the response is which of those things? Oh, everybody's answered already. Okay, so correct answer there is B, excitatory. So acetylcholine makes an excitatory response at the nicotinic receptor. All right, so onward. So how, okay, we've talked now about how the autonomic nervous system works. Now we're going to look just briefly at what does it do. given this structure. So what we're going to see is that practically the whole body is innervated by the autonomic nervous system. Now, all of the organs have innervation from both, the sympathetic and the parasympathetic. But a lot of other parts of the body have only one or the other. So let's just go through the body and look at some examples. All right, so in the eye, the sympathetic division causes pupil dilation. So it causes the pupil to get bigger. It also causes accommodation. Now, accommodation is a trick the eye has for serving two different functions. On the one hand, our eyes need to be able to see clearly at a distance, right? So that we can be familiar with our surroundings. But for the human being, we have this neat little trick where we can also see things up close very clearly. And that trick there is accommodation. The lens in our eye changes shape so that we can see things up close and we can see things far away. So the sympathetic division triggers distance vision. Now this kind of makes sense. In a fight or flight scenario, what's here is not as important as what's further away, right? So it sets the eye up to be very sensitive. In other words, pupil is wide open, but also be able to see at a distance very clearly. The parasympathetic division does the opposite. It causes constriction of the pupil and accommodation for close vision, so up close. Okay to look at things up close when there's no mountain lions around, right? All right, the lacrimal glands, here's an example where there's only parasympathetic innervation. So we get nothing from one side, but we get secretion. So tear production is governed by the parasympathetic division. In the skin, one of the themes you'll see is the sympathetic nervous system innervates everything, practically. I mean, this is a rare example. And that's because it goes all over the body. Sympathetic fibers are found almost everywhere. The parasympathetic division only goes to the organs for the most part. So it goes only to specific places where the sympathetic kind of goes everywhere. So when we get to the skin, we'll see we have no parasympathetic innervation because there aren't fibers to the skin. But the sympathetic branch controls sweat gland secretion as well as those little erector pili muscles that we learned about almost at the beginning of the semester now that causes the hairs to stand up. So that's skin. Cardiovascular system, you can see a large predominance of sympathetic effects versus parasympathetic effects. And here again, it's because the sympathetic division runs with all the blood vessels. The parasympathetic division only goes to the heart. So we have a lot of difference here. And here we can start to see how the different receptor types matter. Beta-2 receptors cause dilation. Alpha receptors or alpha-1 receptors cause constriction. So we have a variety of different effects. This is not a memorizable table, okay? So please don't spend a lot of time looking at all this. I'm more interested in you knowing what we've already talked about, as well as what I'm trying to show you here is that the effects are opposite. What the parasympathetic division does is opposite the sympathetic division. Don't be memorizing all these beta-1s and beta-2s. All right, so let's just do some examples. So like in the pancreas, insulin secretion. Here we have an opposite effect. Parasympathetic causes an increase. Sympathetic causes a decrease. In the pineal gland, melatonin, same thing. Increase and decrease. They're opposites. All right. In the, let's see, all right, anyway, not too interesting tables. They're interesting to go through, but not step by step like we would have to do. So, onward. This is really the whole point, is that the two are in balance. They're in opposition. So the heart is the classic best example of this, because the heart is innervated by both the parasympathetic and the sympathetic division. When one goes up, the other goes down, and we see sometimes additive effects. So like we'll start here. This is a common resting heart rate, so 72 beats per minute. If the parasympathetic stimulation increases, the heart rate will decline. So the sympathetic hasn't changed, the parasympathetic has gone higher, so the heart rate goes down. If we take that stimulation away, we go back to baseline. Now here, we can get this effect, an increase from 72 to 100, this could be either the parasympathetic innervation went down or the sympathetic stimulation went up. So either thing is going to look the same way. Because if the sympathetic division increases its stimulation, that's going to cause the heart rate to increase. But if the parasympathetic decreases its stimulation, we're going to get the same thing. So then what about this big peak here? So this is kind of a maximal heart rate. You know, you might encounter this with maximal exercise. So we get this when we have both things. So we have sympathetic stimulation increased, parasympathetic stimulation decreased. So we get the heart at maximum rate. So by having these two systems in balance, it gives the nervous system a lot of control over things. Instead of just turning it all the way up or all the way down, instead we have this stepwise increase. So we can create a heart rate anywhere in between these by adjusting either the sympathetic or the parasympathetic up and down. So the divisions are in that opposing balance. All right. So why have this ganglia in the first place? You know, why this additional complexity? By having the autonomic nervous system with a synapse on the outside, so outside of the central nervous system, it makes this possible, which is what we call a short reflex. So let's say there has been some change in an organ. There are receptors that are going to detect that change, and we're going to talk about some of those here in a minute. But that stimulus heads towards the autonomic ganglia, and right here in the ganglia, in a short reflex, we can create a response to that stimulus without ever entering the central nervous system. So these short reflexes are very fast because they don't have to involve the brain or the spinal cord. They can just occur right here at this ganglion. So probably the reason why we have this extra synapse in the autonomic nervous system is for speed and responsiveness. So we've got a short reflex. Short reflexes usually control small, simple things in a small area, all right? But if the change is more complex or requires more effects on more different places, now the body is going to go ahead and use the central nervous system. So in a long reflex, those receptors go all the way into the spinal cord, that have a synapse, and then come all the way back out through the ganglia and out to the effector. So this is a long reflex. Slower, but it can have a greater effect because it doesn't necessarily have to stay like at this level of the spinal cord. It can send information up or down too, which in this short reflex you don't have that option. So we've got short reflexes and long reflexes. So just some examples. This first one, the cardio-accellatory reflex. In ANP2, you do a lab on this, but it's something we've all experienced. You know, if you've been lying flat or sitting down for a long time and you get up very quickly, you know, you get a little woozy and if you feel your heart start to pound, that's the cardio-accellatory reflex. When there's a sudden decline in blood pressure, the body's response, its immediate initial response, is to increase the heart rate and increase the heart's force of contraction to try to get that blood pressure up before you go passing out. So that's one example of, and here the stimulus is that decrease in blood pressure, which is picked up by a receptor in the carotid artery. And then the response is coordinated through the brain stem to increase that heart rate by increasing the sympathetic nervous system stimulation. All right, so there's one. The pupillary reflex, we've all seen this. When you shine a light at somebody's eye, their pupil gets smaller. And that is a visceral reflex. When light levels are too high or too low, there's either dilation or constriction of the pupil to accommodate for that. All right. Let's see. So all of these, you know, swallowing, coughing, baroreceptor reflex is all about blood pressure. So where are these baroreceptors? A baroreceptor senses pressure, all right? So that's useful in a lot of ways. So the one that we already talked about was this one, the carotid sinus and aortic sinus. These are inside the blood vessels, and they monitor blood pressure. You know, without blood pressure, blood doesn't flow, and without blood flow, tissues starve for oxygen and nutrients, right? So the body has to maintain a blood pressure all the time so that we know blood can flow all the time. So the sensors for that are found in the carotid arteries and then in the aorta. The brain is such a critical organ to the body's survival, and the brain is so delicate and sensitive in terms of its needs that it has its own receptors for things like blood pressure and blood chemistry. So the body takes particular care of the brain, which is why we see that we have two of these. The carotid goes to the brain, the aorta goes everywhere else. In the lungs, we have some baroreceptors to prevent us from overstretching our lungs. In theory, our muscles are strong enough that we could damage our own lungs by breathing too hard, essentially. So the baroreceptors prevent that from happening. If the pressure gets too high or too low, it'll stop that inhalation or that exhalation. In the colon, baroreceptors are used to determine how full the large intestine is, to determine GI emptying or defecation reflex. Let's see. And then in the bladder wall, it's baroreceptors that determine when the bladder is full. So that sensation of the need to void comes from baroreceptors in the bladder wall. So these baroreceptors do lots of different things. We also have chemo receptors that are part of the autonomic nervous system. These detect chemical changes. So the three big things that the body's worried about second to second, so to speak, is pH, PO2, and PCO2. pH, of course, is the level of acidity. PO2 is how much oxygen there is in the blood. Our cells need oxygen to live. And PCO2 is the amount of carbon dioxide in the blood. We have to get rid of carbon dioxide as well as bringing in oxygen. So we have three different places in the body where these levels are detected all the time. So in the brain itself, in the respiratory centers of the medulla oblongata, we have a pH sensor and a PCO2 sensor. In the carotid bodies that go to the brain, we have same thing, pH, PCO2, and PO2 detectors. And then also in the aorta, we have those same three things. So why those three things? Those are the principal determinants of whether the body is getting what it needs right now. In other words, is it getting enough oxygen? Is CO2 being removed rapidly enough? And is it getting rid of enough waste products to keep the body functioning normally? So next semester, when you talk about the respiratory system, you're going to see that these three things are what determine how deep and how fast we breathe, as well as the cardiovascular system, how fast the heart beats and how that blood is distributed. All right. So the autonomic nervous system obviously has to be under control of the brain. And the system for that is unfortunately sort of complex. So all I'm showing you here really is that the control of the autonomic nervous system happens at multiple levels. The hypothalamus is typically referred to as the ultimate controller of the autonomic nervous system. And the hypothalamus is really in charge of most bodily functions. It's well underneath our conscious awareness, but it's the part of the brain that controls all that stuff that keeps us alive, basically. So it controls downwards. The pons, the medulla, even the spinal cord and itself all have autonomic nervous system cells in it. So the hypothalamus controls down. But then the hypothalamus itself is affected from above. So it's affected from the conscious mind, from the limbic system, things like emotions, memory, responsive behavior. And then it's also affected by the thalamus. And remember, the thalamus has all of the sensory information going through it all the time. So the hypothalamus is well connected, and it means that our sympathetic nervous system, or rather our autonomic nervous system, can do some pretty fancy things. Like knowing that the mountain lion is maybe a threat. If you think about just how complicated that is, you're going to have to involve lots of different parts of the brain, right? Because you're turning a thing that you have seen into something of meaning, oh my gosh, it's a mountain lion, to a decision, I need to do something or the mountain lion is going to eat me. And then all the while, the hypothalamus is gearing the body up for that response, so that your blood pressure is appropriate and your oxygen levels are appropriate so you can either fight or flee. So, we oftentimes talk about the brain in different pieces or parts, but you have to remember that in the end, the whole thing works together to make whatever happens happen. All right, so complex control at multiple levels. All right. So I introduced this chapter by saying that it's one of the most important chapters in A&P1. I want to show you why, okay? Now, none of this information in the next 3 slides is testable because this is not a medicine class. I just am trying to show you how the stuff you're learning really does play into our everyday care of patients, which almost all of you will be participating in at some point. All right, so let's look at some examples of sympathetic nervous system and medications that are used to either trick it or affect it. All right, so anybody have asthma? Raise your hand if you have asthma. Okay, so you've probably heard about this. It's an inhaler. If you've ever seen an asthmatic use an inhaler, what they're using is what's called albuterol, which is a beta-2 adrenergic agonist. So what does that mean? Adrenergic means it affects the norepinephrine system, right? Agonist means it stimulates or activates that receptor. So albuterol activates beta-2 receptors. So where do we find beta-2 receptors? On the tubes that go down into the lungs. Beta-2 receptors are inhibitory, right? So if we activate an inhibitory receptor, we're going to get an inhibition. And that's exactly what we see. Albuterol activates beta-2 receptors, then those beta-2 receptors cause those tubes to get bigger. And it opens up the airways so that the asthmatic can get air in and out like we're supposed to. So albuterol, very commonly used medication, and you can completely understand its effect by understanding the autonomic nervous system, so beta-2 receptors. All right. A beta blocker has become one of the most prescribed medications in the world. And what a beta blocker does is just what it says. It blocks beta receptors, and usually the target is the heart. We want to block beta receptors on the heart. Why? Well, it turns out that the harder that the heart has to work, the more oxygen it needs. And the more oxygen that it needs, the higher the risk of heart problems from lack of blood flow. So a lot of people, by the time they get to 50, the vessels that supply their heart are not as big as they used to be, from atherosclerosis, arteriosclerosis, all those things. So beta blockers prevent the sympathetic nervous system from turning the heart up as much. So we get 2 effects. One is the heart needs less oxygen, but the other is the heart rate and the blood pressure don't get as high as they do without a beta blocker. So we see these very commonly used, and the biggest reason for that is they have been shown to reduce the risk of death in all different kinds of illnesses. So things like diabetes, heart failure, hypertension, any of those illnesses, if you're on a beta blocker, you're less likely to die, basically is what the studies have shown. So huge numbers of people are on these. And here again, you can understand the effect by understanding how the sympathetic nervous system works with its 3 receptor types or its 5 receptor types. So given that albuterol activates beta receptors to create a positive effect, opening up the airways, you can imagine that beta blockers might be a problem there. Because if the beta receptor is blocked, now how can albuterol open those airways up? Well, it can't. So the first generation of beta blockers was contraindicated, or you wouldn't give it to a person with asthma because it potentially could trigger an asthma attack. Now, the new generation of beta blockers only affect beta-1 receptors. The pharmacologists and the biologists have gotten that good. They can affect just one receptor and not any of the others. So we don't see this effect as much. All right, so beta blockers. Alpha blockers are used to lower blood pressure. Why? They affect alpha receptors. Well, if an alpha receptor is blocked and an alpha receptor is stimulatory, in other words, it makes smooth muscle contract, If we block the alpha-1, we're going to cause the blood pressure to go down because the blood vessels are going to dilate and cause less resistance. So we see it used there. We also see it in things like prostatic hypertrophy, where we're trying to shrink an organ. If we stimulate those alpha receptors, we can make less glandular secretion, which causes the size to go down. But think blood pressure for the alphas. Here's a medicine you've probably all taken, Sudafed, which is pseudoephedrine. You know, you have a cold and your nose is all full and your sinuses are all full and you reach for the little red tablet called Sudafed. Well, how does it work? Well, Sudafed triggers the release of norepinephrine from sympathetic nervous system postganglionic neurons. Okay, so this is right here on our picture. So Sudafed makes this happen. It triggers the release of norepinephrine. Now, why does that do us any good? Norepinephrine affects alpha-1 receptors, which cause vasoconstriction, right? Shrinks the blood vessels so less blood can flow through them. So if we activate these alpha-1s by activating these neurons to secrete norepinephrine, we get less blood flow to the nasal mucosa. Less blood flow means less mucus production. So the nose dries up because the blood flow has shrunk down to nothing. Which is why if you take too much of Sudafed, your nose can get so dry that it'll bleed or you'll get into a long sneezing fit. Because it needs to have a little moisture and a little blood flow to work right? So that's Sudafed. In addition, this effect is happening all over the body. So pseudoephedrine can elevate blood pressure by triggering the release of norepinephrine from sympathetic nervous system postganglionic neurons. So we have to watch that, particularly in patients who have a high blood pressure anyway. All right. Epinephrine, released from the adrenal gland and from adrenergic neurons, is probably the most important resuscitation drug. So you've had a heart attack, you've drowned, you've been hit by a car, you've had some massive trauma, you fell off a 5-story building. Regardless of what shut your heart down, epinephrine is probably the drug that can start it back up. We all see on the TV the electricity and the paddles. While that's important, it's not as important as the epinephrine that was probably pushed before that happens. Epinephrine stimulates the whole body towards recovery, basically, or activity. So epinephrine is given frequently when we're trying to resuscitate a person, and its presence is necessary, usually, to get that heart rate back with the paddles. So before they do the shocky thing, they're probably going to push epinephrine. Sometimes it's pushed directly into the heart muscle itself. You'll see that in TV, great big long needle that goes into the chest, and it looks very dramatic. But what they're doing is they're putting epinephrine right into the heart because that's where they want it. They want epinephrine in the heart so that the heart wants to beat, and it wants to beat faster. All right. We also use epinephrine when we're suturing. You can imagine that if you have a cut and you want to stitch it up, well, it's going to keep bleeding, right? How do you see what you're doing when it's bleeding all the time? Well, a trick that we have is we can inject epinephrine around that area, and it closes the blood vessels off by stimulating those alpha-1 receptors. So it makes it so we can see what we're doing by basically turning the blood flow to that region off. Now, you don't want to do that for very long because without blood flow, the tissue will die. So it's a temporary trick that we use to reduce blood flow while we're cleaning or suturing. All right, we're almost done. Alpha-1 agonists. These stimulate alpha-1 receptors specifically. So if we gave an alpha-1 agonist IV, in other words, it would circulate all around the body, we would have a massive increase in blood pressure because all over the body, the vessels would get smaller. They would vasoconstrict. Smaller tubes create higher pressure. So a medication like phenylephrine would cause a massive increase in blood pressure. Now, where have you maybe seen phenylephrine? in decongestant nasal sprays. So if you've ever used one of those sprays to make your nose less congested, that's an alpha-1 agonist. And it has the same effect that Sudafed does. By causing vasoconstriction in the nasal mucosa, it reduces the amount of secretion. You know, the mucosa can't secrete if it's not getting the fluid in the first place from the blood. So it does that same thing. Now, rarely we will actually use phenylephrine IV in a patient who has a very low blood pressure for some reason, like from shock or sepsis or something like that. The problem with it is it has a tendency to starve the body for blood flow. So we get a blood pressure, but we don't have any blood flow because all the vessels are too small for the blood to pass through it. So typically you see it in the decongestant nasal sprays. A warning, those nasal sprays are addictive, and here's why. The neurons start to get used to the presence of this alpha-1 agonist, and they get kind of lazy. So they don't make their own norepinephrine as much. So when you stop using the phenylephrine, you get a flood of congestion because the blood flow is not being controlled like it usually is because you've made the neurons kind of lazy. All right. And then the last one is in ophthalmology. When you go to get your eyes checked, typically they want to dilate your eyes, right, so they can see better. Well, the medication that they use to dilate is another alpha-1 agonist because alpha-1 receptors trigger pupil dilation. Now, if they wanted to constrict your pupil, they would use acetylcholine. Now, why would they want to do that? Well, in certain kinds of glaucoma, it's better if the pupil is smaller. So patients with chronic glaucoma will usually use acetylcholine or a similar medicine all the time to cause that pupil to constrict, to reduce that pressure. All right. See, so there's all kinds of useful things that you've learned in this chapter. You just don't yet know how useful it is. But when you get there, maybe you'll be happy that you learned it now. All right. So let's do some questions and then call it a day. Which of the following is not an effect of parasympathetic action? Well, we got a wide range on this one. A lot of uncertainty on the answer to this question. All right, jump in there, last couple people. All right, so when you think parasympathetic, think rest, digest, and secrete. You could add another word there, rest, digest, and secrete. Because the sympathetic system, except for sweat, has a tendency to turn secretions down, and parasympathetic turns them up. So an increase in tear production, that's parasympathetic. The lacrimal gland is innervated only by the parasympathetic. Motility of the intestines, that's digest, right? So parasympathetic, that's digestion. Gastric secretion, that's digestion. So what's out is metabolism. So C is the correct answer. The parasympathetic division actually slows metabolism. Now, why would it do that? Because in rest, of the rest and digest, we want to store up nutrients for when we need them. So the parasympathetic turns the metabolism down and promotes things like weight gain, protein synthesis, things like that.
So would it be better to take your vitamins at nighttime before you go to bed?
Yes.
Okay.
Yes, it would. All right, which effector has... I'll almost skip that because we didn't go into all that. Which of the following is not a sympathetic effect on the body? That's a good one. Oh, no, not a very good one. Sorry. I want to see how many more we had left. All right, jump in there, last person. We got a. Who put E? Somebody put E for real. It's right here on my screen. All right, which of these does not belong? A. Coagulation is very much a chemical process. It doesn't have any innervation. But the rest of those things are things the sympathetic division does. So far vision, constriction of the pupil, it should be dilation of the pupil. Anyway. And decreased insulin secretion. All right, that's it for today, folks. We're done a little early.